Thank you. Okay, good afternoon, folks. We're here this afternoon. We're going to be taking up a bunch of testimony from community partners regarding the budget. And first off, thank you to everyone who sent me their requests. You will see in the upcoming agenda that not everything that you asked for you're getting, but we're trying to have a representation of the various areas that we have jurisdiction for. Because we do have limited time and we have lots of things to get done in addition to the budget. So the first one we're going to hear from is Vermont Care Partners, representing the designated and specialized service agencies. So the floor is all yours, Amy. I don't think we need to do introductions. You've been here many times in the last few weeks. So welcome to our committee this afternoon.
Thank you. For the record, Amy Johnson, Director of Government Affairs and Communications from Vermont Care Partners. So naturally, you know me, I'm very wordy and I have 15 minutes and
Very wordy. I love that. I love that.
and I made it 27 slides. So I made sure that you all have rich content. I tried to make it abbreviated. I won't go over every slide, but I think it's important that you have them all. And there can be conversations that we have outside of this presentation.
Thank you.
So just to level set, there's 16 designated and specialized service agencies across the state of Vermont. There's the map showing where they are, where they live. And then, this one I think is really important because people often don't understand how many designated agencies are there, how many specialized service agencies are there, and what do they do? So this really lays out designated agencies have a catchment area, specialized service agencies don't. There's some nuances between, for example, Upper Valley Services is a designated agency, but
We know all about that.
you got it? Okay, great. Well, that's perfect. So that's in there for additional reference.
I appreciate it because I always like, there are 11 designated agencies, not 10 designated.
Right, exactly. So I think that's important to note. Just really quickly wanting to show a slide that people often think we're treatment and recovery, but there's much more: promotion, prevention, early intervention, home and community-based services for both DS and mental health and substance populations. So that was just a level set real quick. So
And Amy, just to, so that everybody knows, and if you have it coming up, then that's, I won't dwell on it, but it looks like you're moving into what the asks are. Could you just describe the people that you serve?
Yeah, thanks. That's great. So we have mandated populations, so individuals with serious mental health issues. We support people with substance use barriers. We support individuals with intellectual and developmental disabilities. So there's specific mandated populations, but as a whole, we're in community supporting folks who are high acuity and also doing prevention and promotion and early intervention work for children, adults, and individuals with intellectual and developmental disabilities and substance barriers. So it's really vast. It's a lot more vast than people often think. We're here for every Vermonter.
And I think we have a quick question for Representative Donahue.
Yeah, but thank you. Just to clarify, because I know Pathways is not part of Vermont Care Partners.
Correct.
But they are a specialized service
Correct.
agency.
Yes, absolutely.
Okay.
Yes, there are two that are not part of Vermont Care Partners.
So they're not, neither of them are listed.
They're not listed as
Specialized community
Specialized
services.
services.
Specialized community services in Addison County. For people with.
Oh, is the other one
Is
that's
the
an
other one
SSA that's not a member?
Yes, not a member, yes.
correct.
Yes, how come they're not members?
Because it's a dues paying organization, they've chosen not to.
Oh, just because they're not. I didn't know.
They're
if
not
there's-
being excluded, they're always welcome.
They're not closed out.
I didn't know there was something other, like some kind of
No.
structural type of thing.
Yes, absolutely. Always welcome. So I'm going to start with our elder care program, and then I'll move into our larger budget ask. So elder care program, for those that don't know, this is homebound older Vermonters who have mental health and substance use challenges that limit their ability to come into the office and receive care. So we know that we're one of the oldest states, aging state, I think fourth oldest state in Vermont, that's per Dale. And we need to ensure that we're supporting our aging population. This program has not received an increase in over 20 years. And so, again, I have limited time. I'd love to go in more depth around this program, but here you'll see fiscal year 23 data on who's providing the service. Some folks are providing it in their catchment area and also other catchment areas as well. But you can see the clients that they serve. Are they holding a wait list, which is most of the service providers, and then everyone but one is running at a deficit. The need for this program is $453,000 in general fund for it to be, it has been level funded for years. This is really critical program. And we really love to see support invested in it.
Thank you. Representative Norris has a
Just wanted to thank you for this. Thank you.
A lot of you when I put this in here as the primary slide, so.
I do note, however, that only 11 of 14 counties are served. And so what's happening in the other 3 counties?
So a couple of these, a couple of the agencies serve multiple counties.
Yeah, I counted them all up.
Okay. I can look into that.
Okay.
Yes.
Because again, if this is I realize that this is not necessarily what is a mandated program. Checking my math. Go ahead.
No, I was at, because I did this earlier, actually, when I thought Northeast Kingdom covers 2 counties.
Oh, Northeast Kingdom covers 3 counties.
3 counties, sorry, 3 counties,
Okay.
yes.
Yes, sorry, I wasn't counting that.
Thank
Yes.
goodness.
And then I believe,
13. Anyways, okay, I just want to make sure that there's statewide coverage. Okay.
I will clarify that for you, but I did the same counting
Okay, thank
earlier,
you.
yes. So any questions on elder care before I move into our larger ask? So I just want to note that back in 2017, some work was done to change statute language that suggest or put language in that the Secretary of AHS shall adjust rates to take into account factors that include any reasonable costs of government mandates. You can see the language there highlighted. It also talks about cost adjustment factor, including those attributed to inflation and labor market dynamics.
Can I just back up just a quick, you said on elder care, 453,000 in general fund. Is that matchable with Medicaid? I'm understanding, my recollection is that some folks are Medicaid eligible, others are not. Is that correct?
I believe it's matchable. I will get that information for you, double check. I don't want to say something out of turn. All right, so we've worked to shift language, and the hope is that like our state partners, that regular predictable increases based on inflation will be happening for our folks. That has not happened. So I'm going to move into what our ask is this year. So I will say that our across all 16 agencies, our CFOs came together and did a robust analysis of what the needs are to keep the lights on. So they looked at a variety of factors, including, and you can see here, the 5% recommended 5% salary increase for staff based on the U.S. Bureau of Labor Statistics. While this might seem high to some folks, based on what's happening in our workforce across the country, this is the recommended statistic. Average projection for health insurance increase of 16.6%. You can see other fringe, 10.8% in increase in insurance rates, and then 3.3% in other operating based on New England Consumer Price Index. So this is not a percentage in dollar amount that's plucked out of the sky. This was a lot of work that was done to figure out what is the need. So the gross need you can see there is a little over 34 million. the FMAP state match, 42.17, and then what the actual ask is, I should have circled it in red, is $14.6 million for the DA and SSAs. And again, this is for us to keep the lights on.
And do you have this broken out by population? Mental health, substance use, developmental
We
disabilities?
can very easily.
Okay, that would be helpful. It would be helpful actually to know what each 1% by population, what would be needed for each 1% of an increase.
Okay. I'm gonna go back and, it looks like I'm not taking notes and not caring, but I'll go back and watch this.
And yet, the benefits of YouTube, right?
So that's the 3.3, you're, right, each 1% of that.
So I can go back.
It's the 14.6 million. I want to know, broken out by each population, and then what does each 1%
Increase.
represent in the COLA? And the COLA is made up of all of these things on the right-hand side.
Okay.
Okay,
So, this is, don't do this on a PowerPoint, put lots of things in. This was a good idea at midnight last night. But I think it's important to note that, you can see on one side, we talk a lot about staff. Staff need to keep up with inflation. And matching inflation helps us to maintain the status quo, so we want to go above that. Level funding is a cut because of inflationary pressures. We are losing staff, although I will show you that the increases that we've received the past 2 years have started to turn the curve on those rates, but it's really difficult to recruit staff when we can't tell them we're not sure if we're able to give you an increase. So one of the things I want to hammer in is that a cut in wage will undo the progress made. So we've started to make progress. We've started to see a turn in the curve on staffing, turnover, and vacancy. It will take a little bit longer for us to see the curve turn for the population that we serve, because those relationships, building those relationships and working towards goals takes longer. But we know that we've made some headway and we don't want to backslide. And then the benefits, retention benefits clients, again, who need long-term trusting relationships. There's a lot of other things here that I think are important to note, but I know that I'm limited in time. So we know that staffing shortages reduce capacity for our community-based wraparound support. So eroding our home and community-based supports, that's our promotion, prevention, intervention services that are really critical for kids, families, adults, and individuals with disabilities. If we don't have staff, we lose bed capacity. You can see the risk of that. There is homelessness, need for inpatient care, again, reducing crisis bed capacity, school-based community integration. So when we are not able to recruit and retain staff, the onion starts to really peel, and that's demonstrated here. Yay, some good news. So I want to highlight that we really appreciate the work of this committee and many others around our increases. We received an 8% increase. You can see the purple line demonstrates the increases that we've received over time. I thought it was really important to have raw numbers in here. You can see orange is how many positions that exist across the DA and SSA network. And then the green is how many staff we currently have. So you can see that positions are starting to increase. We're starting to add more. You can see vacancy and turnover data decreasing, and you can see that connection with the purple line, those increases there.
so I'm just wanting to be sure, I don't think I'm reading this correctly, but if I look at 7/1/23 and I look at the blue that says FY turnover, total staff who've left, are you saying that that's, 1.1%?
So the percentages on this side are connected to the COLA, the increase.
Okay.
Yeah. So if you look on this side, you can see the number.
It's the number.
Yeah.
Yeah, okay.
Yeah, we tried to fit everything into one slide just to be able to show. We use percentages, but folks are saying, well, what are the raw numbers on that? And it's seeing that we have 6,000 positions across the entire system.
And over 1,000 of them left during the year.
Right.
Is that the way to read that?
Yes.
Okay.
15%.
We have percentage slides too that I can offer you, but. So we are in a critical, we don't want to shrink our services. We don't want to do less. That's what we've heard, should we rein it in and do less? And I think what the needs and costs to support vulnerable Vermonters will not go away. It'll just move to a different part of the system. It will show up in more costly interventions. So it's really important for us to invest in our high-end system, crisis 988, mobile crisis, mental health urgent care. That's really important. And we need to invest in promotion, prevention, early intervention, and treatment as well. So we're going to grow that kind of crisis end if we're not investing in the full system. It will, if the system does fail, there's profound effects to vulnerable Vermonters and also puts demands on public safety services. And then you can see the health and safety of vulnerable Vermonters will be at risk if services are underfunded. So I'm a big iceberg fan, except for when it comes to the Titanic. But this really demonstrates what people perceive that we do. Kind of the high end supports is above the water, and underneath you can see all of this care coordination, advocacy, housing, social determinants of health work, just a array of supports and services that are kind of supportive, front end, not that high end, which again is important. And so we know that the high end is there and it's necessary and we are investing in it. But if we're not investing in the full system, we can see that this has the potential to flip and have the iceberg be mostly high end, which is very costly.
And I'm just going to encourage you to focus more on substance use services and folks with intellectual and developmental disabilities, because that's what we have jurisdiction
Right.
about here. That's
Well, this is forever. This is the whole system. The
okay. I was just seeing the headlines in mental health services.
Yeah, sorry. I will edit that, but this is the entire system.
Thank you.
For us. Yes. And so we know that wage burnout and administrative burden are the three main reasons why people leave the field or leave their positions with us. And so it's really important for our staff that they have salaries that empower them to meet their basic needs. People are often reluctant to take positions where we can't guarantee predictable increases. And when somebody leaves, that workload goes to another person. I don't want to go into the other ones as much. You can see that there. And then this is from the Direct Care Workforce Consultancy Project that was done with Dale, where we can see that what would help you stay. This is our home and community-based service staff supporting our IDD population, and higher wages is obviously the biggest one for that population. Why might you leave low wages? And then we have burnout as well. The rest of the slides are really speaking to testimonials of staff that we have currently or have lost. I don't know that I have time to read maybe one or two, but if not, they're there for you to see. And I think they're really compelling. The first three are our mental health staff, and then the second three are specifically our staff that support the IDD population. And I do want to note, I think it's really important from an RBA perspective, despite the fact that we've been chronically underfunded, we are doing a lot. So you can see our numbers on our disability services and supports serving over 4,600 Vermonters. And then you can see from a mental health perspective that we are serving large numbers of individuals and that we are seeing, these are our outcomes. So how well and is anyone better off? I think the staff treated me with respect is really important, 93% of respondents. And then I received the services that were needed, 87%, and that they made a difference, 89%. So despite what is happening in the agencies, the staff that are working, everybody that's making up the system are working incredibly hard to make a difference and support Vermonters, and this continues to happen despite the underfunding. And then this is just a slide to say we are trying to find other ways to make, to bring in revenue in new and different ways. And so we are, many DAs are working to become certified community behavioral health clinics. I won't go into too much detail about that. That's a whole other conversation, but just showing that we aren't doing the same thing. We are being innovative. We are trying to find solutions alongside working with our state partners. And then our impact report is done, so you can read all kinds of stories from every single DA and SSA to learn about the innovative things that we're doing to support Vermonters in substance, mental health, and IDD.
And if you click on that, you come to the report.
You do.
Which I just did. Okay, we have time for a couple of questions. We got Representative Brumsted, then Donahue.
Thank you. Actually, this was excellent. First, for me, it helped me better to understand all that's going on under the DAs. I was just curious when I looked at the charts showing why people leave and why people, this one, survey spotlights, what would help you stay? Why might you leave? I was just curious. Higher wages, of course. Have any of the DAs tried more time off, knowing that they have the burnout? And I wondered, that means you have to hire more people, but it might alleviate some of the burnout factor. And I know that.
I think there's been many different approaches across the DA SSA network to support staff to, we think about that iceberg kind of at the center is the staff. And so ensuring that they're healthy and well. So what we've heard from, just anecdotally, if we offer staff additional time off, they say, well, if I take additional time off, I'm going to come back to a million emails. I'm going to come back to clients who, needed to be supported. So that workload that exists for folks when they take time off feels overwhelming to them or can feel overwhelming to them. And so that's something that we do here, although not to say that agencies haven't tried that as an approach. We've had other agencies start employee leadership groups where employees meet once a month, specific kind of representatives come together with leadership from the agencies to talk about what's going on the ground, what area needs. For example, our cars are getting torn up because we're driving all over on these dirt roads, and can we each get a AAA membership? Things like that we're really listening to. What is going to make you feel supported and help you to stay here? And I think all of those things are great. And people need to make sure that they can pay for their housing, pay for their childcare, pay for their food, those basic needs. And that's why the wage really comes to the top of the pyramid.
Thank you. Representative Donahue, you'll have the last question.
It's not a question. I apologize. It's something I need to say. If I've already said it in this committee, just shut me up. I don't think I have. I don't think it's come up here, but members of my community, many members of the psychiatric survivor community have repeatedly said how deeply hurtful and offensive the language behavioral health is. And yet, even though many agencies and many places in the state recognize that and stop using it, that there are many that do not. And so just seeing the language is always upsetting and hurtful to me. And I know this is a federal title. Guess what? The feds have never heard of Three Squares, Vermont.
Right.
We use our own terms when we choose to, and yet we choose to not disassociate ourselves from a known, hurtful, offensive, and not even accurate term.
Thank you.
Thank you, ma'am. Okay, Amy, thank you very much for being here today. And we look forward to a deliberative process as we try to, ferret out all of the needs of Vermonters here. So thank you. Okay, is Mark outside?
Right here.
Oh, I didn't see you. You snuck in. I didn't even see you.
Stuck in the dark of night.
How'd you not see him? You walked right in.
I was so concentrating on Amy's.
He's
behind the iceberg is what it was.
Oh.
That's right.
Welcome, Mark, to our committee. you actually haven't been here this year at least, so.
While,
Well, why don't we just do a quick round? You probably know most people. Teresa Wood from Waterbury, Bolton, Bealsgore, and Huntington.
1981.
1980.
Go back. We go back, Ann and I,
Georgefield in Berlin.
New York City.
Yeah, right.
Manhattan.
Times Square.
Yes, that's right.
Good story.
Good afternoon, Dan Noyes, Wolcott, Hyde Park, Johnson, and Belvedere.
Gage Scribner, Fairfield, Fletcher, Makefield.
Hi, I'm Jubilee McGill from Bridport, and I also represent Middlebury, New Haven, and Weybridge.
Kelly Priella, I represent Londonderry, Andover, Weston, and Wenham.
No, Hyman, I represent South Burlington and Willis.
Dave Lemon from Bennington.
I'm Mark Traeger, father, Essex and Essex Junction.
And Mark Kelly Smart from Winooski.
Hello, Jessica Brumstead, Shelburne and St. George.
Right? And my wife used to be in this committee and just texted me, tell everyone I said hello.
Right there.
Oh, it's back there.
Dane stealing her seat.
Lorraine West Committee Assistant. That's
Amy?
Oh, I'm sorry, Amy Schulter.
Sure.
Association.
Matt Levin, Vermont Early Childhood Advocacy.
Patty? Yeah.
Colorado. Claire Kendall from a Parent Child Center Network. Amy Johnson. Family Accident Party.
Great. Okay. So, and hi back to Mary Beth.
Yeah, Mary Beth as well. There you go. So thank you for having me today. So I am the Director of Spectrum Youth and Family Services. We're based mostly in Burlington. We've been around since 1970, and we work with teenagers and young adults who are homeless, kids who are runaway, kids who are in or exiting the foster care system, in or exiting the children's mental health system, young people in the juvenile justice system, young people who may have dropped out of high school, unemployed, underemployed, and it's usually a combination. So it could be somebody who is homeless, who is also have substance abuse disorder, right? Or somebody who is a runaway, who also was in the juvenile justice system. And we help them in a variety of ways. We have a drop-in center in Burlington where young people can come in and get a free hot lunch and free hot dinner, change of clothes, do their laundry. Community Health Center has a health clinic in our building, so they get free health care. We have 16 beds upstairs for young people to live in, a 10-bed warming shelter, a few beds away, blocks away. We have mentoring. And we also started a car detailing business a few years ago, teach kids a trade and how to work. So we do all those things, and we do what's called a youth development program. There's one in every county in Vermont. It's funded by DCF, and we do it for Burlington. We've done it for like 20 years. We work with people, young people in the foster care system, young as 14 all the way up to 23. So we're helping them finish high school. Do they want to go to college? Do they want to go to a trade school? What's credit card debt? How do you find an apartment? How do you drive a car? I always say I was lucky. I had parents to teach me these things. We're going to teach these young people. So we've been doing that for years. And about 10 years ago, DCF approached us and said, Spectrum, will you start doing this in St. Albans? So we hired 2 staff. We rented space up in St. Albans. And those 2 workers never let me forget. They kept saying Spectrum needs to be up in St. Albans, you know, in a bigger way. And we looked at some, and there's a lot of strength in St. Albans. You know, there's development, there's nice hotels going up, there's housing. Beta is opening up a new battery. There's a lot to be said for St. Albans. But it's interesting. People kept talking about above the tracks and below the tracks, and they literally mean it. And if you go below the tracks, there's a lot of poverty, substance abuse disorder, homelessness, domestic violence. So those workers said, Mark, we need to be up there. So somebody donated a major gift to us, $200,000, and then we got a federal grant. So we opened up a drop-in center right on Lake Street. In fact, if there is a picture, I sent some slides.
Yes, we have
Yeah, yeah. If you want to put the first slide up, it'll show you, well, what it's like. But
Easier said than done, Mark.
yeah,
We can all, we.
Yeah, you can see. So it's great. Yeah, it's beautiful. It's beautiful. We have a place where young people can come and get hot lunch, hot dinner, do their laundry, take a shower. NCSS comes in and provides mental health treatment. Vermont Adult Learning will provide tutoring. State just picked us to start doing mentoring. So we're doing that, and we have the youth development program. So we were surprised because most of the youth in our drop-in center in Burlington are like 18, 19, 20. We were very surprised in St. Albans to see that group, but also 13, 14, 15, 16, 17 coming to our drop-in center. Why is that? Because in Burlington, we're quite fortunate. We have the Boys and Girls Club, the King Street Center, the Sarah Holbrook Center, beautiful YMCA. They don't have any of those things in St. Albans. So we're really functioning as kind of both, like a Boys and Girls Club, King Street Center, and also a Spectrum. So when we opened up, we wrote a grant and said, how many youth are we going to work with in the first year? So, well, maybe we'll work with 80 youth. Well, we ended up working with 189. And the last year, 304 youth came through our doors. So we're seeing a lot of young people, both the younger kids and then also the 18 and above. So here's the need. The need is for some kind of housing, not permanent housing, but some kind of shelter housing. So in Burlington, and Taylor's on our board now, we have a 10-bed warming shelter. And then up above the drop-in, we have 16 beds. And young people will live there, not only be fed, we'll help them find a job, we'll help them finish school, we'll help them learn how to budget their money. We have someone who teaches them how to drive a car, and then they can stay for as long as 3 years. Most people stay about a year and a half. And it really works. That model really works because we have the time to help them with all those independent living skills. So that's what we want to do. We don't need 16 beds or even a 10-bed warming shelter. I think we need between 8 and 10 beds somewhere in St. Albans that would be linked up with the drop-in center. So that's what we want to do. Now, there are hotels, right? So if someone is homeless and they need a hotel, well, there's 78 hotel rooms up in St. Albans. They're all filled. So the other day we had 4 youth with nowhere to go, and the state said, we have a hotel room for them in Bennington. We have a hotel room for them they're not going to go. First of all, how are they even going to get there? And they don't know anyone there. And I'll be honest with you, even though we need the hotels are not a good place for a teenage boy or girl. They just are not. So that's what we want to do. We want to create somewhere in that vicinity. So, I asked my staff, just give me one case, one little vignette, who needs help? And they said, this past year we got a youth, just turned 18, struggling with mental health, substance abuse issues, came in to get food, use our shower, do his laundry, and he was living in a tent city, which is 2 blocks away on Lake Street. Mm-hmm. And we give him camping gear, which I'm embarrassed to even admit. We give out camping gear. We're in Vermont, we're giving out tents to people. That is not right. We helped him get his basic needs met. We provided support in navigating complex systems like food stamps, Medicaid. While he was with us, he was given a sense of safety. In fact, he brought in another homeless youth with him. He would benefit from a regular residence to stay in, okay, rather than living in a tent. We estimate that right now, I asked my staff yesterday, there are 18 youth right now. Who could use a place to live in our age group? There's 18 youth right now. There is Samaritan House. You're probably aware of that. I called Paul Dragon yesterday. How many beds do you have at Samaritan House? 20. How many openings? None. How long is the waiting list? 50. So it really is no place. Mm-hmm. And that's what we want to create. We want to build out. We're building it out. The state now is paying us to do what's called a COMPASS program. How do we prevent kids in Franklin County from coming into foster care? We're doing that. We're doing the mentoring. We're trying to almost duplicate in St. Albans what we've got in Burlington. But the key piece is going to be the housing.
Thank you. Can you be a little more specific about what your ask is?
So to run the drop-in center costs us $404,000 a year. And of course, federal grants in. We are pretty successful at fundraising. We have the sleep out at Taylor Park, March 28th, if anyone feels so called. So we'll probably raise around $200,000 up in Franklin County to support. But the drop-in center costs about $404,000. So we need about $200,000 to supplement the drop-in center. And to run a residence like that, that's expensive. That's about $454,000 per year to run like an 8 to 10 bed residence.
Okay, I just want to make sure I'm clear. 454,000 and about 200,000 for the drop.
That's right.
So, again, you funded the drop-in center on, philanthropic,
Yes,
one-time gift.
and a one-time CDBG federal grant. Yes,
Okay.
yes.
And so do you get any ongoing state funds for that drop-in center?
No,
So you have no source of funding for that drop-in center now, but you must.
except it's running, the federal grant is running out and yeah, so.
Representative Gregoire.
Yeah, I was just gonna say, first of all, thank you for all the work you do.
Sure.
I don't think that a lot of people really understand, maybe they do, but I know in a lot of our world, they don't, how dire some of the situations are in Franklin County. Like, you don't really think of it. Sometimes when you run into people in the field, they're like, the issues in Franklin County oftentimes surpass other places that get more attention. So I'm really happy that you're doing your work there, and I've had the opportunity to discuss with the boss lady back here about what exactly you do and how much you're helping. And the idea about the beds, like we talked about, the money is an issue, obviously, but we don't have a lot of resources up there. So I'm hopeful that we can help in any way we can, because there's a lot of kids up there, there's a lot of people, period, but a lot of kids that need the service pretty bad.
Yes, yes.
And I think the 2 or 3 10 cities that,
Yeah.
in the city that.
Can I just ask it,
Yeah.
have you applied for funding through VHCB?
So we would do that. I would apply that because we did that to create a new residence 20 years ago in Burlington. So I would apply for that for like the bricks and mortar.
Right,
That's what I would apply for.
and so the 454 is
That's
operating.
operating,
Okay.
right.
Okay,
Or we've been successful. We just bought a new building for counseling. Somebody donated $1 million and somebody else who lost a child to suicide donated another 400. So we've been pretty successful in terms of bricks and mortar being able to
okay,
either give VCB or donated money.
okay, thank you. Representative Grafano, you have the last question.
Sorry if I missed this, but do you have a location identified already? Because that sometimes is a barrier.
Yes, we will have to look for one. The building that we're in now has apartments upstairs and the owner wants to sell it to us, but it's not the right building. What makes the Burlington building work is we have 16 beds all on one floor with one adult awake overnight here and one adult awake overnight there. And so the building we're in it's got hallways and we would lose control. So we will have to look for a place. But I feel confident talking to my contacts up there. We could find a spot.
It's brief.
Quick Compass program and just
Yes.
foster program in general. How many of your kids that you see in St. Albans are in the foster program or just coming out?
So we have up in St. Albans, in the youth development program, they're in foster care. They might have been removed from home when they were babies, right? And now they're 13, 14, they're living with foster parents, aunts, uncles, grandparents. So we have about 26 young people we're working with up there right now. And unfortunately, we have about as many people on the waiting list. So not for that. So Compass was created by the state to keep young people out of foster care. So DCF becomes aware of there's problems with this youth, could be problems in school, we have problems at home. We don't want to pull them out of the home and put them in foster care. So they use us to go into the home and into the school. So we have 36 youth in Burlington with a waiting list of 36 because I met with them this morning. We need more staff for that. And we've got about 20 people up in St. Albans in the Compass program. So Compass, I love. The state funds that. And we all want to keep young people, right? Safe, in home, in the school, out of the system. Everybody benefits from that.
Thank you so much.
Thank you so much. Thanks everyone for the time. Thank you.
Okay, Claire, you're up next. And my apologies to folks, we are running about 15 minutes behind. I didn't understand you.
I never.
Welcome, Claire.
Thank you so much. Good afternoon. I'm not sure, Lori, if you could put up the.
Can you, actually, we prefer if you can run it yourself, if she gives you co-host authority. Is that okay?
Sure,
Okay.
Do you have the link, the Zoom link?
I do. I'm not on the Wi-Fi here. So I'll start by,
Can I just make a statement to anybody else who's going to be testifying this afternoon? That if you have something you want to put up on the screen, that you join the meeting. Thanks.
thank you. Um, so I'm connected and, I click at the link. Okay. And I'll start by introducing myself while, Zoom opens up. And it's not the end of the world if I can't get this to connect.
We do have it. It is nice for people who are watching this because they aren't necessarily having access to.
Perfect. So I am very appreciative. Thank you for your time today. For the record, my name is Claire Kendall. I'm the co-executive director of the Family Center of Washington County, which is the Parent-Child Center for Central Vermont. And I'm also currently the Vermont Parent-Child Center Network co-chair, along with Courtney Farrell from Lund in Burlington. So it is connecting. Great.
Looks like you're up there.
Yay.
Big eyes on that little.
That's Michaela, my 9-month-old granddaughter.
Ah, she's adorable.
Oh, yeah. She is for sure. So I'm sorry, should I keep my video on and off and should I mute?
You should mute.
Yes, I'm muted.
Okay, now just share your video, share your screen.
Thanks. Okay. Why?
Maybe you should just get started.
Yeah.
I just don't,
Yeah, I was pretty close. And then that share screen link kind of dropped from my view. So thank you very much to this committee. Thank you for your support for the passage of Act 150 in 2022 for the Parent-Child Center Network. That statute was recognized and it's codified our partnership in terms of working with the state and the Child Development Division and supporting our 8 core services. So just for your information, what I'm looking at is the slide deck that says impact report. Or no, actually, I think I'll do there's 2 ones. We'll do the one that's titled testimony.
network presentation. Yeah.
And
You're not gonna have time for both of those.
no, I wasn't going to.
Okay.
Thank you very much, Chair. And so if you look at the second slide of that, we serve 18,656 children statewide and over 17,000 parents. Our network is comprised of 15 parent-child centers across the state. Our strengths-based multi-generational approach serves both children and families, and we lean into the core services, and those are offered consistently across the state, in addition to a number of other services that are unique to each region that each parent-child center offers. In terms of looking at ahead at the data slide in terms of the core services, it has them listed, and each year, twice annually, we conduct a family survey as part of a requirement for our contract with Child Development Division. And so you can see some outcomes in terms of parents reporting. 94% reporting feeling stronger and more confident as a parent, and 98% reporting feeling that they got the supports that were right for them.
Which is great.
And why does that matter? Because across the state of Vermont, we're in the throes of actually lifting up 100% Act 150. We're in active conversations. In the next slide, you can see that we are actively engaging in a network, within the network, and also with our state partners. We meet twice monthly with Helen Child Development Division. Deputy Commissioner McLaughlin has fully endorsed our process in terms of negotiating contract specs, performance measures, as well as scope of work.
Oh, Lori is coming to the rescue. You're on the screen.
Thank you so much. What do I owe you? I was hired a chocolate in my bag. I'll come back with one. Thank you so much. In terms of in terms of standing up Act 150, that we were asking for an increase to our base funding to provide staffing and infrastructure support, which is a critical element to being able to receive the grant and one contract with the state, and then to have subcontract days and subgrant agreements with the 15 parent child centers. And the other working requirements, which you can see in the next slides, which include having staff benefits, financial processes, protocols, bylaws, and insurance that's required for state government contracts. So on the next slide, the other companion to our appreciation for our support that this committee passed on to appropriations and passed the funding increase for our salary and benefit packages, and that was significant. And one of the attachments that I had sent over to Lori was our impact report, which I know that some of you have received already. But it shows that every single parent-child center used those resources last year to increase salary and benefits, and some parent-child centers that did not for benefits previously now do. So everyone is offering a benefit package of health insurance, and some parent-child centers were able to increase their salaries up to 20%, which is significant. So what we have seen in a result of that, our parent-child center alone, we went from over 6 vacant positions to now, maybe at one point we had close to 9, including our childcare program. We have 2 now vacant positions. So that's significant. And we have not had a resignation since we've increased our salary and benefit package in July. So there's a tremendous amount of appreciation that the network has. And part of the downside to that is when the health insurance costs were increased for 2024, it's eroding into that already. And so this request, because of increases were experienced 12 to 14%. We put some dollar amounts together that we have a spreadsheet that quantifies what that impact is, depending upon how many staff at each PCC receive health insurance. And if you can see on one of the other slides, it's not part of this, it's part of the impact report. That equals over 400 staff across the state of Vermont that are employed at parent-child centers. So that's the impact on a staffing level. So the next slide, the total ask is $721,945 for a combination of Act 150 standing up that in its entirety and the increase in health insurance costs. And so progress to date, if you can see, the legislature passed, again, thank you very much to this committee. We couldn't have done it without your support. And our partnership with the state is stronger than it's been in quite some time. And that feels tremendous. In terms of the second bullet, we're working to support staff in terms of collecting data. We're providing technical assistance to PCCs. We're supporting each other in peer support, for peer review, for process through the quality standards. So programs are able to move through the standards and adhere to different phases and different levels. and especially onboarding when there's a new director, which there is in Hartford in the family place, and in Springfield, there's a few new directors. And so we provide technical assistance internally and support and mentoring. The third bullet, the network, something we're really proud of is having those strides made. We have a finance committee now for the network that we've stood up. A number of CFOs from different parent-child centers are members of that. We're getting consultant support from Margot Holmes at Blue and Heron Consulting, a former director of the PCC in Springfield. And we're developing draft scope of work, budget, and policies and protocols. We're going to have governance and bylaws, and that's all in work in process with our consultant project. And so the fourth bullet is we're finalizing an executive director job description. The draft has already gone out to the member board leadership, and people are reviewing, providing feedback, and then we'll be able to turn around and post that position as a next step, and then we'll be able to have the capacity to receive the integrated grant through the network directly as of July 1, along with a lot of the necessary processes. So here's a little bit more detail for that. It's a 5%, 340,000. And here are some bullet points in terms of what it would go towards. You've already heard me talk about staffing, but obviously bookkeeping and CFO duties, payroll, as well as insurance, legal fees, professional development, and audit expenses. And here's a breakdown of a very high level overview of the budget, a consolidation, and this would be for FY25, so the year beginning in July 1, this calendar year. And we also, we had transitioned, we had been in calendar year contracts. We have one standing amendment left that's going to be, we are in, and it's January through June. And so July 1, we will go to fiscal years from then there forward. And lastly, again, thank you. I apologize for the technological glitch in the beginning, and I hope this didn't feel rushed, but I'm happy to answer any questions, and again, appreciation for this committee's support.
Thank you. Thank you, Claire. So I'm going to start off the question. So I know we had a lot of discussion when that bill passed.
That's right.
And I'll be honest, I don't think that the legislature was intending you to come back and ask for resources to stand up the network. That'd be like, sorry to put Amy in the spot. That'd be us like the legislature specifically funding Vermont Care Partners. It's a membership organization. People are members. They pay dues in order to support whatever they feel like they need from the organization. So I'm just laying that out to be perfectly open about that.
Yes, thank you.
So then my second question is, so then you're saying the balance, the 381,945 is all for health insurance?
Yes, across the 15 parent-child centers, based on that aggregated spreadsheet. Everyone has different percentage of their staff that are enrolled in benefits of their agency.
Questions?
This may be not a very good question, but I don't know. How come under benefits it says 28%, but up above it said 16 point?
That was the increase, 12 to 14%. That was an increase.
And the 28% is the.
The 28 would be the fringe for the staff for the network.
Okay.
All the different.
Okay. Thank you.
Yeah, I think my only response, I think Representative Wood, all due respect, we do pay dues, and we know that we have to have a Plan B budget, and we're having those conversations actively. And what we all know that is if we don't get an increased funding that comes through an administrative appropriation, it will result in decreases in our direct services budgets, and that's where we're going to come from. Because we are committed to this and it's going to happen. And we have also pursued private foundation funding and we've written 2 grants and we plan on writing a 3rd.
Thanks.
All right, thank you.
Thank you, Claire.
Thank you all so much. Thanks for your time.
Okay, Helen. Helen with all the moves on the dance floor.
Wait, are we still streaming?
So
I was listening to the concert, but I was like watching Helen the whole time. I'm glad I didn't know that at the time. Sorry. Adam Ezra concert on Friday. Helen was there. No, it's a compliment. You're like, whoa.
So welcome to our infomercial for the Adam Ezra group.
Tune into House Human Services. What does it mean? I'm sorry to embarrass you.
I'm not going to sing any of his tunes. That would be truly embarrassing.
I sing harmony, but I'm terrible.
So I'm Helen Lavin. I represent the Vermont Healthcare Association. I'm their executive director. And we're here today speaking to, we have two membership groups, the assisted living and residential care homes, and then also skilled nursing facilities, both of which are in your budget. And so I'm going to be speaking to both of them. You have a presentation that I submitted with a lot of text on it. My intent is not to go through that live, but to just give the highlights so that you can review it in your leisure. I will start, and I will say I'm also focused narrowly on the budget here. So I'm going to start with the assisted living and residential care home section, which you heard a lengthier presentation on from Laura Pelosi last year, I believe on my first day in the job as executive director. So a lot of this will be review. We are paid in those provider types through for the Medicaid payments are assistive community care services, or ACCS, and then enhanced residential care, or ERC. There was a rate study that came out from DEVA last year looking at the difference between at the cost of providing those actual services and what's reimbursed by Medicaid. And thank you very much to this committee and others in the legislature who did make up the rather sizable gap in that ACCS section of 80% to bring us up to cost of services. Enhanced residential care, on the other hand, received a 4% increase, but the gap was still quite considerable, depending on what tier, was up to 60% below cost of services.
Well, they got the 79% plus the 4%.
So, right, so ACCS is the foundational services, and then as the enhanced residential care would imply, it's the additional services for different levels of need. No surprise here, we would like to be made whole on the ERC side. So the ask on this one is simple and follows with what we presented on last year to bring those enhanced residential care rates up to the cost of services. I would note that there's a new twist this year in that the Division of Licensing and Protection has proposed updating the regulations for assisted living and residential care homes. They were quite out of date. Everyone agrees that they do require updating. However, in that enhanced residential care bucket, there are some pretty sizable changes that will be quite costly to providers. So we're looking at both being 60% behind going into those changes and then having more costs on top of that. So, we're trying to get out of this cycle of having to every few years have a major increase to make up for low payments. So that's what we're essentially trying to avoid here. And you can see more details on the slides that I submitted for those.
What's the difference between the black and the red?
The red is 2023 closures. So that was just highlighting that these aren't all during the pandemic and immediately afterwards. So we're continuing to see a trend in losing ERC beds. I did accidentally cut off the bottom line of that chart. There is a total net loss of 180 beds. But also on there, you'll see there's also a change in beds that accept these different payment types. And none of the beds that were gained are off of that enhanced residential care. So we're seeing particularly steep declines in that bucket that is so far below cost of services, as economics would lead you to expect to see. So basically, I'm telling you, this looks the way you would expect it to look if there's an underpayment in enhanced residential care. The second half is the skilled nursing facilities. And if you look at the slide deck, I did my level best to explain plainly how rate setting for skilled nursing facilities works
It is not uncomplicated. So I will leave those details to the brave souls who want to venture through that slide deck. But here's our highlight in looking at skilled nursing facilities, which I know that Dale came in and presented, and there are increases proposed in the governor's budget, looking at statutory inflation increases, stabilization, and then a second sort of separate bucket for the iCare Mission Care project. I should say we represent providers who are currently operating in the states. We do not currently have that group as part of our association. So I cannot speak much to them because they are not yet part of our association. Looking at the rest of the skilled nursing facilities in the budget, what we're talking about is long-term care Medicaid. So that's excluding some of we have a handful of private pay and continuous care communities like Wake Robin. So it's not speaking to them. And additionally, the Veterans Home is funded differently. So we leave them out of those calculations that we're presenting here. But with the 32 providers that are Medicaid accepting, Medicaid matters a lot for them. It's a large part of their provider share. Basically, they have access or they don't based on what their Medicaid reimbursement is. And we've had an extremely unstable cost environment. And but the good news is we have a lot of data on that. So it requires a lot of spreadsheets, but you can look into the data and see how far short the Medicaid reimbursement falls from the actual costs of providing these services. And a lot of what's in the slide deck gets into the details of that. But the short story is it's driven by workforce. So we can look at workforce costs, and then we can also look at labor market trends and see have they changed recently. And on the one hand, it's not as steeply bad of a curve as it used to be, but also it's plateaued at a pretty bad place in terms of workforce availability and cost. And when we add all the numbers together and take out what's been proposed in the budget, we still come up with a gap of about $10 million on top of what's been proposed for the increases. And 10 million is a somewhat conservative estimate. That's 10 million to keep things as they are right now. So not looking at expanding access, not looking at complex care, just looking at getting by until the next fiscal year. So the corollary to that would be we would like $10 million more in the budget. And that money is going to come from somewhere. These are operating costs, right? We're not talking about we lost value because real estate holdings changed. These are the costs that go into actually running these facilities. In the past, when it's been a smaller amount and there were more reserves, often facilities could absorb the difference, and you could push it onto providers until the next rebase and adjustment. That's no longer the case. We've spent down our reserves. We can also do one-time investments, and you've sort of seen that retrospectively with the extraordinary financial relief that's been going through. So that's a kind of last option if a facility is in fear of closure, putting that in retrospectively. We would like to get out of that cycle and plan in the budget for what the true costs are going to be. And there are also one-time investments you can do through that. And then also we could redo the rate methodology to make it match more with what the current costs actually are so that providers know that their costs will be covered and should, although everyone scoffs at me when I say this, it is still true. If we have a reduction in workforce costs, then it goes down, right? You're not carrying the extra rents from the inflated place that we are right now. And then, of course, on the flip side of that, there's also the option of not putting that money into the system, which at this point I would say would almost invariably lead to a lack of access or reduction of access. And that can be either through running at low capacity, and we do see facilities now that are unable to get beyond a pretty low capacity for how many beds they can staff or what types of care plans they can provide, or a delicensure of bed or closure of facilities at the extreme end. So, they're not a lot of choices right now, but we do believe that there is that $10 million gap in what's required to keep facilities operating at their current capacity for the next year.
Thank you, Helen. So I have a question around the proposed change in the rules around occupancy.
Yeah.
So, I mean, we hear on a pretty consistent basis about lack of availability of skilled nursing beds, kind of across the state. But here particularly in Chittenden County and in Washington County. And I'm just, I realize it's a financial calculation, and I realize, but I guess what I'm trying to figure out, what incentive then will it be for skilled nursing facilities to be at a higher occupancy rate than 80% if it moves from 90 to 80?
Right. So there's a couple of things in there. One thing that should be noted is that part of the occupancy is based on what's considered safe or appropriate for a facility. So there's an upper cap of where you don't want them to be passed, and that's in the 90 to 95% range for various reasons, including infection control protocols and ability to convert rooms to private. So what we're really talking about is that 80 to 90 band in there.
Yeah, that's
and I would say that what's constraining on that right now is workforce, either at the basic level of staffing for nursing or to match the individual treatment plans, the individual who's going into that bed. If you're losing money on every person you accept, then, right, the calculation does not become great for accepting more folks because you're just going to lose more money. But if that's your position, then you've got bigger business issues, right? If that's prolonged. In theory, facilities should be breaking even and making money. In other states, you hear Vermont's unique in that our facilities are stretched for capacity to accept more patients or more residents. In other states, the concern is more going the opposite way, that they have too many beds and people are fighting for admissions. That is not the case in Vermont. So some of the policies from elsewhere in the country don't make as much sense right here because we have done a lot of investment in drawing down any overcapacity in beds, and we're now at a place where we are not at overcapacity.
I guess I get that we're not at overcapacity. You know, probably there might be some people who might disagree with that, but I happen to agree with that. And I'm not sure that there's a good answer to this, you know, to my question, but I think that, do you know what other states have in terms of reimbursement rules around occupancy, or is Vermont unique in that way?
Vermont's not unique in that way. Other states have the occupancy rule. It tends to be set as is described in the report, as I also added. So it used to always generally be set on what the average was, because the whole goal of these guardrails is to avoid outliers. So you want to keep people sort of moving as whole. So when you read, for example, the report on the occupancy minimum, it talks about what the average is, and that tends to be 80%, like Vermont has. Sometimes it's a little bit different in those states that approve specialized units. So like if you're going to set up a specialized unit, say for dementia care, they might set it higher because they're you're created for the purpose of taking stress out of the system, and they want that to be as high as possible. And then the idea that there's an upper cap is more new after the pandemic. So that's a new best practice that has emerged since COVID-19 and in response to that. So that's an emerging element that we see primarily in best practices.
So the 80%, moving from 90 to 80 results in facilities not being penalized, I guess, if you will, for not being at the 90%. I still am concerned, quite frankly, about that. It doesn't help us incentivize them to go between 80 and 90. What do we do to move up? It's a rhetorical question. I'm not expecting a particular answer. I just am concerned that we actually can't afford to lose more capacity. And
well, I shouldn't speculate on the feelings of other states, but my understanding from my colleagues is less that the individual facility won't be incentivized to take residents or patients, and more that there isn't any cap on overbuilding in a region. So it's more of a, are you overbuilding capacity in beds concern more than does the individual business owner make the decision to accept someone or not accept something? So it's a little bit of an apples and oranges what that's intended to incentivize.
Yeah, I mean, I don't think we're at risk of overbuilding capacity in Vermont.
Right, which is why I think that probably is, similarly, it's not going to be a concern that an 80% minimum will have an impact on an individual provider's decision to accept or not accept a new resident. A much higher impact will be how much below the cost of providing services is being provided for that individual, or simply, do we have access to the workforce we need to complete this care plan?
Thank you. Other questions for Helen? Okay, thank you so much for being here.
Thank you.
Hey. And Jill, thank you so much for signing on.
Yes, I thought I would do it one person ahead just to
Thank you.
make it doable. Now we'll see if I can actually
Trying to get brownie.
do it. I am trying. I need them.
Chair is awful tough, dude.
I did it. It looks like I've had some practice, so it is a little bit of a stressful thing to do in front of an audience. So good afternoon. I'm Jill Olson. I'm the executive director of the VNAs of Vermont. So we represent the local independent home health agencies, so the ones that have a specific geographic county-based territory. We don't represent Viata, but we do certainly try to work closely with them on any policy requests that we make. I don't see any daylight between us and them on rate increases. So I think I should also state for the record, I also have dance moves, and if anyone wants to learn how to West Coast swing, a new series. Okay.
Thank you for bailing me out of that.
Yes, no problem. Okay, so I always start with this slide just to remind any audience sort of all the different things that a home health agency does, and then I'll sort of dive into what I'm talking about today. So home health agencies actually have a span of services. We provide skilled home health services, so medical care in your home, usually following a hospitalization, but sometimes not following hospitalization. Sometimes we get referrals from physicians in the community. And that's mostly under the Medicare program, a little bit under Medicaid. We mostly talk about this down the hall in the healthcare committee. But this skilled service is where nearly 20% of Vermont's hospital discharges are going right now. So absent is that skilled service, and this is really our primary work, I would say, in a lot of ways, we would have an even more substantial discharge problem than we already have. We also have some prevention services. We do maternal child health. We do some screenings. We do some vaccinations. I'm going to skip over long-term care for a second because that's where I'm going to be for the rest of this presentation. We do end-of-life and palliative care. So we provide hospice services in all settings. So hospice is a service, not a place. So it's something you can have in your home, in a facility, in a hospital, lots of different places where hospice happens. And then
just a quick question about that, because I know that, there's been some work in Vermont around access to hospice and trying to increase awareness among people at that stage of their life, in terms of trying to access and referrals. And how is Vermont doing? Are we doing better at accessing hospice, or?
Not really. And actually, I think the last report said we actually lost some ground, a little bit of ground. I'd have to go back and look. The health department just did a report. I view that question as, or sort of the, where do we need to improve, is in many ways, it's really a physician issue more than a hospice issue. So it's really the specialties that are taking care of people who would really benefit from hospice. That's where I think that education and change has to happen to help those physicians think about when they want to start referring their patients to hospice. I think the other thing, and we're talking about this as part of the AHEAD waiver, is that one of the really tough things about hospice is that you have to give up on curative treatment. You have to give up. So you can't get that holistic service until you've given up on treatment. That's why we have a pediatric palliative care waiver in Vermont, because giving up on treatment is super hard for parents with kids who have probably terminal illnesses. So we actually have created a flexible program in that regard. And there's lots of talk about how to sort of get people the benefit of hospice, the counseling, the grief work, the supports for the family, the goal setting, all of these holistic things that happen as part of hospice that you need, even if you're super, super sick. And it's, anyway, that's a big policy discussion that is mostly a federal policy discussion, but possibly some room in our healthcare reform effort to broaden that a little bit. And that's something we have advocated for. Yeah.
Thank you.
Sure. So going back to my chart, so long-term care. So primarily, home health agencies are right now the only provider type that can provide services, personal care services in homes. So that is the services that people need in order to remain independent when they are on long-term care Medicaid. So they are eligible for Medicaid. They have the financial eligibility, and they are clinically in need of a nursing home. So what I always say is that anybody who is being taken care of in Vermont by home health is a person who is not being taken care of in a hospital or in a nursing home. We are providing capacity that would otherwise be in those settings. Not everyone can be at home. Many people need those settings, but what we want to do is reserve those settings for the people for whom that is really the most appropriate choice. So we've been doing the Choices for Care program since it started. We've done the personal care, some homemaker services, and then also case management. So a blend of those things. And we'll talk about where that's going in a minute because it's relevant. So when I'm here talking to you about the budget, I am only talking about our long-term care Choices for Care request. We also have a skilled request that we're making down the hall. So there are a lot of pressures on home health agencies right now. I'm not sure why that beeped at me.
I don't know. So it's all good.
Okay. So there are a lot of pressures on home health agencies in a way that really there weren't even 5 years ago. So we have the cost of travelers to preserve access to nursing and therapy services. All of my members are still grappling with needing to hire travelers. The IRS mileage rate is a huge deal for us because we pay people for their mileage based on that rate. And it never goes back down. Even if when gas prices go up, it never goes back down, even if the gas prices go down. So that rate is high, and it got really high in 2022 and has only increased from there. So that is a huge pressure on agencies, and it's not directly reimbursed. We don't get directly reimbursed for that payment. Workforce shortages. And in the long-term care program, we are competing with everybody. So we're competing with many employers. These are not jobs that require licenses. So we're competing with people who might otherwise work at Walmart or McDonald's or those kinds of places. We really are trying to make headway on wages, salaries, and benefits, but they already far outpace the rates that we get paid. But there's so much pressure that I know you've heard about from everyone on those areas. Then we have historically low Medicaid reimbursement and just chaotic rate increases. They just aren't consistent. They have until the last few years felt a little bit like, sometimes we get them, sometimes we don't, not much related to the need. So I did this math today. So this is prior to the 15% increase that you did last year. She did a big increase last year, but I have data from just before that on both wages and on rates. And so the wage went up 44% while the rate increased by 15%. So this is not working.
Can I ask a question? The rate study was the result of the legislature asking for a
Yes.
rate study on some specific services.
Yeah.
Prior to that, has the Agency of Human Services engaged your provider group in conducting any kind of rate study?
Not for Choices for Care, not in my tenure.
Yeah.
It's just 7 years.
And do home health agencies have access to any kind of extraordinary financial relief?
So I believe that particular program is not available to us, but I can tell you that as we've been working through the closure of the agency in Franklin County, there was state assistance for that effort to keep them open long enough to figure out a plan. So we have received state funds, but I don't believe that particular program is open to home health.
Thank you.
But we certainly call AHS when it's that dire. Absolutely.
Go ahead, Representative Hyman.
Thank you, Madam Chair. What percentage of your patients are Medicare and Medicaid versus private insurance, like, or a long-term
Yeah.
care term?
So it is probably 80 to 90%.
80 to 90%
Of
Medicare. and
government pay.
Medicaid.
Yeah, there's
And-
almost
and-
no
And you
commercial
don't need a
business.
license for, like, palliative care?
You'd need a license for anything that's clinical, nursing,
Sure.
therapy, any of those services. So all of our skilled services that are paid for by Medicare, that's all clinical people with licenses.
Hmm.
What you don't need a license for is a Medicaid-only service, which is personal care. So that's not a healthcare service, it's a long-term care service, meaning you need it over time.
Yeah.
You just need it to be
Washing,
independent at home.
cleaning,
Exactly, all of
And
those.
you have to compete against
Any
market
employer,
rates.
any employer who's hiring for anything.
market rates, and you're getting Medicaid reimbursed.
Correct.
That's a tough model.
It's not working. Yeah. Yeah.
Excuse me, do you, homemaker services are part of that?
Yeah.
Do you, are your agencies providing homemaker service?
Some, yeah, that's gotten really hard to hire for. So less and less and more of that has moved into the flex model where people are using the dollars to hire their own people. Yeah. Yeah, because it's tough.
So related to that, I know, this was, maybe brought up by the, AAA's around the $2 million reduction in the moderate needs program last year. I know that there's at least, I think it was in the Northeast Kingdom, a cooperative arrangement made between the Home Health Agency and the Area Agency on Aging, where the AAA could provide some services that, to, people eligible for choices for care in moderate needs, and the Home Health Agency wasn't able to do it at that point in time. And so they,
Yes.
made some sanctioned switcheroo of funds or whatever. Is that something that is that something that's happening in any other part of the state where there's maybe for whatever reason, inability of the Home Health Agency to either hire staff or, meet that particular need and choices for care?
So I don't know for sure if it is happening. It could happen. It's not, there's no easy mechanism. It takes some effort. And so we were supportive. We would be supportive, I think, of a process to try to figure out how to make that work better, because there's a lot of calculation that has to happen and trying to figure out where everybody's at with their caps. But so I think there's more work to do there. Yeah. Yeah. To make that more workable.
Did that $2 million reduction impact home health agencies?
Not that I can see. I think it was a much bigger impact on the AAAs. Yeah.
Thank you.
So pressures. So how we used to make this work was that we had a margin for Medicare. That's how it used to work. So we used a margin for Medicare to fund what has always been something that's been underfunded. So it's now more underfunded than it was. It's sort of gotten worse, but it's always been a challenging program to support. We had dollars. That's what's changed. These margins aren't there anymore. Medicare has had I just have to be clear, under multiple administrations. This goes back to the Obama administration. This is the over time, consistent desire and effort to make sure that we don't have a Medicare margin, eliminate our Medicare margin, no Medicare margin. And that's partly because sometimes our straight Medicare margin for some agencies in the country has looked high. What Medicare doesn't consider is our Medicaid work. They don't want to subsidize that service, and they're ignoring Medicare Advantage. And so as people are migrating from regular Medicare to Medicare Advantage plans, some of those plans are fine. Some of those plans are paying less than Medicaid. So now you take your best payer, now it's your worst payer. So it's a huge problem. This is the biggest financial problem in home health is Medicare Advantage. NPS is almost nothing the state can do because it's all federal policy. But it's impacting us because we don't have margins anymore. Agencies are spending down their reserves until they close, which is what we're seeing in Franklin County now, where an agency is actually closing its doors. So luckily another agency has been able to step in to provide service there, but that was, I don't know that there's too many more of those rabbits left to pull out of hats. So what's happening with Medicare? So we've got the migration to Medicare Advantage, which we've talked about, but then we've also got Medicare cuts. So they're making cuts. They've made several, and that we expect one more because they're trying to get to about 9.5% cut. It's been sort of better that they've phased in the cut instead of putting it in all at once, except that there's a clawback provision, which says that they can claw back any extra money we got all the way back to January 1 of 2020. So when they phase it in more slowly, that's great, but it means the clawback would be larger because it would just go back to that number. So we're really trying to get Congress to at least say to CMS, you cannot do this clawback. And so far they haven't implemented it, but they could at any time. So those are sort of all the pressures we had going into December, and now we have a new one. This one is not fully unexpected, but it is having a big impact. So I think many of you have heard about conflict-free case management, conflict of interest, and heard presentations on that. So we have a federal compliance issue as a state. So I just want to be clear. I understand that we did not make this box. Our state officials did not make this box. The federal government made this box. But the way we're planning to get out of this box is to eliminate home health from the case management function in Choices for Care. So this starts already, because as soon as the case managers, first of all, they lived through 18 months of what's going to happen, which is not fun. And then as soon as the announcement was made, they now all understand that their role is disappearing. So now they're making decisions as people about what that means and what to do. So the transition is already happening. We've already lost some case managers from the system. And the other thing that's happening is, so one agency had someone who they had just hired, heard the news, rescinded their acceptance of the offer. They just said, I'm not coming to do this, when obviously this is going to change. So home health agencies are trying really hard to hold on to their case managers as long as they can. And these are a very dedicated, thoughtful group of people. So they've stayed, I think, mostly out of their kind of personal commitment. But this is already, we're already sort of dealing with the shift. We have a lot of programmatic and service concerns about this that I'm not going to talk about today because I'm here to talk about the budget. So I just want to be clear. We care about this because we really care about these people, but I'm setting that aside and I want to talk about the money.
Can I just ask a quick question though? So, so what you're facing isn't different than what the designated and specialized service agencies are facing in regard to case management and I guess what I would call direct service provision.
In the developmental services program, they figured it out for the mental health side. So it's not happening. Yeah.
Which is interesting, but, well, I hadn't heard that piece.
No, if you look at the website, you'll see that they've figured out a different way. I am not an expert on this, but as I understand it, they figured out a different sort of channel of the federal government under which to put those designated agency mental health services so that they're not subject to this policy. So I believe it's only hitting developmental services.
It's long-term care services essentially. So I'm just wondering if you had, if the home health agencies had put forth any kind of proposal to be able to essentially figure out a way to manage both within the, the construct of conflict-free case management, which is something we have to do from the federal government.
So that was what we proposed. That was there was an option on the table that would have allowed for us to continue in both paths, and that was not the option that was selected.
Okay.
It does have more complexity for sure to figure that out. I mean,
we're going to be hearing about conflict-free case management in total. Yeah.
But so I think the thing you have to understand though, from a budget perspective, is that this now makes the math of Choices for Care much worse, because the case management program actually often had a margin. Not a huge margin, but something of a margin, meaning some money left over, right? More money coming in than going out for this service. And so that margin was offsetting what was always losses in the direct service side of the house. So now what we're looking at is the revenue from the case management side disappearing, leaving us only with the math of the direct service part of the program. And that leaves less revenue to support the indirect costs of running the program, right? So there's less revenue to apply to all the other stuff that goes into having any program, that you have to have the compliance work, the training, all of that. There's just less revenue to support the whole thing. So I think, and we are definitely at a point now where it is cheaper to not do this service than it is to do the service. I mean, it's as simple as that. So that's any agency would be financially better off moving forward, not doing the service. So where we are with our budget request, oops, it looks like I have a typo there. Sorry about that. So what we're asking of you is to follow through on the discussion that we had last year. DEPA did that rate study, AAA's, ACCS, ERC, home health, the home-based choices for care. So for home-based choices for care, you did a 15% increase. The rate study called for 51. So we got partway there, about a third of the way there. And the idea last year was to do another third this year and to finish it off next year. That's how I understood it as we left the session. And so we are asking you to make good on that plan, particularly in a year when we have this new pressure in the coming through with the conflict-free case management, because everybody's making their budgets now. Like by the time we get to July of next year, this is going to be like long thought through. I have done this is my back of the envelope math. I think, so sorry.
The back of the envelope math is,
Your specialty.
it's a,
You hearing that a lot today?
oh, no, sorry. My apologies, period. My apologies. I didn't mean to. I did not mean to react to that.
That's okay. So basically I took a look at this. I think we would need for the budget, you'd need a more thoughtful estimate. You don't want to involve more math, but
I won't ask you to do math.
Yeah,
when you're sitting.
more inputs, but I think this is I want to give you a ballpark, so you have a sense for what we're talking about.
Thank you.
And then I just also wanted to remind everyone that we know we are part of a larger long-term care system and that needs support. So the ERC is another piece that also did not get up to that 100% of the rate study. And then we also, I think really for all providers, we can't just let it lay fallow until we like all scramble because agencies start to close and beds start to come offline and then we decide to do a rate increase. So it's not a good way to run a system. We really need a process where this can be thoughtfully done on a regular basis. So that's just a long held view that we share, I think, with a lot of other providers.
No, and we've managed to get that bill through the House, but it is never.
I know, we can't quite get all the way.
That's right. I just have one question and then we need to move on to the next witness. Is there any consideration of the home health agencies discontinuing their participation in choices for care?
I think there is. I think that's what boards are going to have to talk about. I mean, what we can't do is just operate at a loss till we close.
Right.
I mean, so I know you guys have a lot of hard decisions to make, but so do these boards. And so we have now for probably 2 years been advocating opening the program to other provider types. My understanding from Dale, I certainly don't want to speak for them, is that they're supportive of that, but there's some regulatory work they have to do to set up a structure to do that oversight. Because there are in fact, it's rare that you have Medicare certified home health agencies providing choices for care type services. In most states, it's these non-Medicare certified organizations that do it. So we are supportive of that, but I don't, and I want to say also, you helped us a lot last year. I mean, I really want to acknowledge it. You got rid of the provider tax. That was a terrible burden. It doesn't change the rate study because it was ignored in the rate study. It wasn't included. So the math doesn't change with the rate study, but it was a huge burden. We got several really important increases. It helped. But when it helped, it brings some of my agencies from like 2 years from closure to 4. Still doesn't work. Like it still doesn't work. They can't just keep spending down the reserves until they're gone.
Thank you. Okay, thank you very much. We appreciate the work that you do.
Thank you very much for the opportunity to testify.
Alrighty. Okay, we're moving on to our last witness for the afternoon. Teresa Vizina, how are you?
Hi, good afternoon. Thank you for having me.
You're welcome.
I've been here before, so nice to see you all again. I guess I'd like to start off first by saying thank you to the committee for the support for the additional $500,000 for the FY24 budget adjustment bill. We're going to continue to work with the Senate to support this appropriation. So as we're really thinking about our fiscal year 2025 funding, for myself and for the other SSPs in the state, we know that we continue to face a pretty critical funding situation. The people that we're serving are in greater need every single day, every single year. And being chronically underfunded for many, many, many years has been really hard trying to do this life-saving work on shoestring budgets with understaffed conditions. But we've been doing the best that we can. And I also would like to say that it was really wonderful in SFY 23. We had received the one-time allocation of $350,000 from the tobacco settlement funds, which was incredibly helpful. And in fiscal year 2024, we actually didn't, I testified then and I said, hey, you know what, I'm not gonna actually ask for any additional funding from the state general funds or any other special funds this year, because we really actually believed that the opioid settlement funds would come through and would address our funding needs. Unfortunately, this actually did not happen, and it came back to bite me in the butt, actually. And the $400,000 from the opioid settlement funds, we are still waiting to receive. And the problem with that is it is now being used to replace a federal grant that ended January 31st. And so instead of actually supplementing our budget, it actually level set that. And we didn't get tobacco settlement funds. So we actually have less funding in SFY 24. And so our biggest concern is we can't really move into SFY 25 at the same sort of state that we're in SFY 24. For our organization, and I know the other SSPs, we all have meetings prior to this, staffing, and I know you're hearing this so much, the workforce it's so difficult. Is there a question?
No,
No.
I can hear you. Sorry.
Okay.
The microphones are picking up people in the hallway outside. Sorry.
Okay. No, okay. And I guess I'll kind of put a little addition here. The health department, we did a survey, which is, you guys will hear the full report soon, but I wanted to highlight one of the really prominent things that syringe service program participants said was the most important and most valuable part to syringe service programs was the people, was our staff, were the people that treated them with kindness and compassion and care, and were there to support them with their needs. This is one of the most important pieces to a syringe service program. We've talked about this before, the ability to build that relationship and that trust and to create that safety for people who so often don't have any other place where they can feel really cared for and humanized. And so, we just heard that over and over again. And right now we're experiencing some of the worst staffing crisis ever. I can only speak for Vermont Cares right now, but we have one singular person staffing each one of our fixed sites. And they're also responsible for doing mobile as well. This is not working. Our staff is so overwhelmed, so burnt out. They're just quitting because they can't do it all. And the work is already pretty demanding, just emotionally demanding. But to be asking a singular person to do the job of what at least two people should be doing, we're at a breaking point. We are literally at a breaking point. Currently, our St. Johnsbury office is unstaffed. So that means we actually had to close and do limited hours. And we have people driving from Rutland to try to cover days, and I'm covering days. And it's so awful to know how people need us and not to be able to be there for them the way that they need is really heartbreaking to me, actually. And so the opioid settlement funds, we really believed that because they were allocated for people who were grappling with opioid use disorder, that we as syringe service programs would receive ongoing supplemental funding to our budgets, so that we could hire the staff, so that we can expand our access, so that we can provide more supplies for people that they need. And we all received $100,000, which again, we're waiting to waiting. We still haven't even received that yet. We've not seen the drug checking RFP come out, so that project has not started. And this year, I was so alarmed to see that syringe service programs were not even included in the recommendation for the opioid settlement funds this year. And it just was so alarming to me, because I feel that syringe service programs should be allocated opioid settlement funds actually annually, until it's expired, quite honestly. These are the people this money was really meant for. And so the ask, for us this year, it's $700,000 extra, but I'd just like to point out that $350,000 of that was a one-time allocation from the tobacco settlement funds in fiscal year 23. So really what we're just asking for an additional $350,000 to get us a little bit more money for staffing, because now that we don't have that 350 going, and we split this, all the money that we have is split between 4 programs, and it's for Vermont Cares, like we have less money moving into fiscal year 24, and then if we also have less money in 25, I don't foresee that we can feasibly continue to operate our programs the way that we have been. So we're pretty nervous. And I thought it might be helpful to share some numbers with you all. And I don't often share data, but I thought, I'll share Vermont Cares numbers, and this doesn't include the rest of the programs. Just since the beginning of fiscal year 2023, our program has distributed more than 1 million syringes, close to 8,000 doses of Narcan. We've had almost 300 reports of overdose reversal, so lives saved. And we know that's a low number because it's self-reported. We have, just Vermont Cares have enrolled 716 new individuals to access our programs across all of our sites. We have seen people across more than 6,000 visits took place since the start of fiscal year 2023. We've given out almost 1,000 referrals to treatment, recovery, and other health and human services. And 445 of those were successful referrals that participants of our program accepted and were connected to. We served 52 different towns across 11 counties. And we're doing this currently with 1 staff person per site. And if somebody quits, we don't have another person for those sites. And all of these people are not being served in the way that they need to. And the other thing that came back in that survey was not open. So I guess that's, we're hoping to see maybe 300,000 from state general funds, and the same 400,000 from the opioid settlement funds. And we're hoping to see that possibly done annually, so that we would be able to support our participants and our staff in a more humane way, actually.
Yeah. We have a couple of questions here. Representative Gregoire.
I know we have to get going, but were you given a rationale as far as to why you didn't receive the amount of money you thought you should receive from the opioid use fund? Just sort of.
So I have been asking for a lot of meetings. I've met with the health department. I have tried to learn who I should talk to about the opioid settlement funds, and I have yet to have a name of who I should really reach out to. I met with the health department, a couple of our grant managers over the last couple of months. So that's kind of what I've been trying to do is I didn't understand why they waited for our federal grant to expire before.
So you didn't get it right now?
No, they just said, we're just waiting for that to expire because we can't supplant, but supplant and supplement are two completely different things. And supplement our program.
My second question is, so just if I heard you correctly, so 1 million syringes, but for 6,000 visits, is that correct?
Yes.
So that's like, that'd be like 174 syringes per visit.
Approximately, yes. We run a very rural programs. So a lot of our participants come on a monthly basis because of transportation. So they're picking up supplies to last them for typically about a month. So it's not unlike Safe Recovery, for instance, that where people are in the downtown area who may be visiting daily or weekly. Our peeps are really coming fewer times. And our mobile, program, similarly, people are picking up a larger amount during those mobile visits as well.
Thank you.
Thank you. Teresa, I did have a couple of questions and we have to move to the floor. So I'm just going to ask, I want to make sure that I understood you. Are you saying that the money that we allocated and budgeted in fiscal year 24, you have yet to receive that money? Is that accurate?
That's accurate.
Okay. Go ahead, Representative Small, and then Whitman, and then we're going to have to close up and move to the floor.
I will defer. I'll reach out to you.
I will be contacting the health department on your behalf, like right now.
Well, that's why I was asking.
Yeah, that's unacceptable. Go ahead.
Thank you, Madam Chair. And Teresa, thank you for being here again, and thank you for all of your work. And I think I speak to the whole committee that it's not only frustrating that you continue to deal with issues and getting the funding that we appropriated for you, but it's disturbing as well. And I just want to, my question, as far as the work that you do as an organization, really appreciate all of the numbers on your overdose prevention efforts. But I think another big part of our budget considerations is really the other facet of syringe service programs, which is infectious disease prevention. Now, I was wondering to what extent you sort of are able to sort of quantify like a return on investment as far as, HIV, hepatitis C treatments and things like that we're preventing through these services.
So our HIV prevention work, really the HIV testing program was, I'll say, put on ice for a little while with the pandemic. The health department, we waited for a couple of years actually for them to come up with a new training for our staff to be certified to be HIV testers. And we are so pleased to say that just barely in the last 4 months, all of our staff were able to attend and become certified HIV testers again. We had a whole new staff, right? I was the only certified tester left on our staff. So I was doing all of the HIV and hepatitis C testing during the time where there wasn't a certification program available for our staff who wanted to do that. So we are now able to have that be done in person again, as it should have been being done for, the whole time. It's been a cornerstone of our work. Our HIV services funding is sort of separate from our SSP funding. And so a lot of our work also is around supporting people who are living positive with HIV as well. So we have not seen within our own organization any increases in HIV transmission, but we do talk to people often regularly about PrEP. So that PrEP referrals, we have hundreds and hundreds of PrEP referrals every single year that we're making to help people get connected. It's a really wonderful preventative medication for folks in the high risk group like injection drug users.
Thank you.
Teresa, thank you very much for being here. And as I said, I'm following up as we speak with the health department, and we'll get back to you and to the others with regard to a response. So again, we thank you for what you're doing for Vermonters and appreciate you being here this afternoon.
Thank you for having me.